Good afternoon, doctors. The topic of our lecture is blood pathology in children, and it is devoted to the most common hematological disorders in pediatric practice. We will start from anemia. Anemia is defined as a reduction of red blood cells quantity or hemoglobin concentration below the level necessary to meet the tissue's demands for oxygen. Classification of anemia. A useful physiologic classification of anemias divides them into three main groups. The first, those resulting from decreased production of red blood cells or hemoglobin. The second, those in which increased destruction of red blood cells is the predominant mechanism. And the third, those with increased loss of red blood cells. The first group, with inadequate production of red blood cells, includes deficiency syndrome, for example, iron deficiency, folate, vitamin B12 deficiency, bone marrow failure, aplastic, hypoplastic anemia, marrow infiltration, for example, leukemia, neuroblastoma, chronic inflammatory diseases, hypothyroidism. The second group, with increased destruction of red blood cells or hemolysis, includes anemia with red blood cells membrane defects, anemia with red blood cells enzyme defects, hemoglobinopathy, isoimmune, autoimmune and drug-induced hemolytic anemias, and the third group are anemia due to blood loss, for example, gastrointestinal, menstrual or trauma bleeding. Another type of classification due to the red blood cells volume includes microcytic anemias due to iron deficiency or hereditary spherocytosis, normocytic anemias due to acute blood loss, most hemolytic anemias, and macrocytic anemias due to vitamin B12 or folate deficiency. And the final classification characterize anemia according to the mean corpuscular hemoglobin concentration. There are hypochromic anemia, for example, iron deficiency, thalassemia, normochromic anemia, most hemolytic anemias, for example, and hyperchromic anemia, vitamin B12 and folate deficiency anemias. Iron deficiency anemia is the most common in children. Its etiology includes dietary insufficiency, increased physiologic requirements due to rapid growth in infancy or adolescence, blood loss, malabsorption. Clinical manifestations of iron deficiency anemia includes pallor, fatigue, anorexia, epithelial abnormalities, including brittle skin, hair, nails, atrophy of the papilla of the tongue with taste changes. In severe cases, tachycardia and systolic heart murmur. Iron deficiency can affect attention span, alertness, and learning. The initial laboratory evaluation of anemia includes hemoglobin, red blood cells, and hematocrit levels, and peripheral blood smear to assess the morphology of the red cell. They are microcytic, mean corpuscular volume less than 75 femtoliter, and hypochromic, mean corpuscular hemoglobin concentration less than 32 gram per deciliter. The level of ferritin, the iron storage protein in the tissues, and serum iron are low. increased total iron binding capacity, decreased transferrin saturation. Occult blood can be detected in the stool. Investigation for malabsorption is necessary in the case of failure to respond to iron therapy. Inexpensive and satisfactory therapy of iron deficiency anemia provides ferric salts, sulfate, polymaltosate. The therapeutic dose should be calculated in terms of elemental iron: 5 mg per kilogram during the first year of life, 100 mg per 24 hours first third years of life, 100 to 200 mg for elder children. The hemoglobin concentration should be restored to normal within 2 months, but an additional 1 to 2 months of therapy should be administered to replenish iron stores. Parenteral iron preparations indicated in the case of malabsorption, but with the risk of anaphylaxis. Blood transfusion is indicated only when the anemia is very severe. The family must be educated about the diet with iron-rich food, for example, meat, fruits. Vitamin B12 and folic acid deficiency causes megaloblastic anemia. Before 1926, megaloblastic anemia was fatal with unknown etiology and treatment. Vitamin B12 and folic acid are important cofactors for DNA synthesis, and their deficiency affects red blood cells, white blood cells, and platelets production. Etiology of megaloblastic anemia. To be absorbed in the ileum, dietary vitamin B12 must combine with intrinsic factor, which is secreted by the parietal cells of the stomach. Most cases of vitamin B12 deficiency result from a lack of intrinsic factor. Dietary deficiency of vitamin B12 occurs in strict vegetarians who avoid animal products, including milk and eggs. Vitamin B12 can be removed from the intestinal tract by heavy infestations of the tapeworm Diphyllobothrium latum. Clinical manifestations of vitamin B12 deficiency anemia includes irritability, anorexia, glossitis, nausea, constipation or diarrhea. Neurological manifestations of vitamin B12 deficiency differentiated from folate deficiency and include paresthesia, sensory deficit, hyperreflexia, and slowing mental process. Laboratory investigation for vitamin B12 deficiency anemia. Macrocytic anemia with mean corpuscular volume more than 100 femtoliter can be associated with leukopenia, thrombocytopenia, and hypersegmentation of neutrophils. Megaloblastic erythrocytes have a short lifespan, and their destruction leads to increased levels of bilirubin. Parenteral treatment with vitamin B12 is highly effective, with prompt response after administration 50 to 100 microgram of vitamin B12 or 1 milligram in the case of neurologic symptoms. Vitamin B12 should be injected daily for at least 2 weeks. Folic acid deficiency can result from inadequate dietary intake, malabsorption, for example, celiac disease, chronic infectious enteritis, or drug interactions associated with some anticonvulsant and trimethoprim sulfamethoxazole. The diagnosis is confirmed by the determination of serum folate. For treatment, folic acid should be given in a dose of 1 to 5 mg per 24 hours orally for 3-4 weeks. The next is aplastic anemia. Marked decrease of the hematopoietic cells in the bone marrow with replacement by fat tissue is typical for this disorder, which results in profound depression of all the elements of the blood. Aplastic anemia is classified into constitutional, genetically determined Fanconi anemia, acquired, idiopathic or induced by drugs, toxins, infectious, particular hepatitis, and congenital hypoplastic anemia, pure red blood cell aplasia or Diamond-Blackfan anemia. Constitutional Fanconi anemia is most usually present at birth. Is not usually present at birth. The clinical onset occurs from 1 year to 22nd year of life, with an average of 6-8 years. Bruising caused by thrombocytopenia is noted fast, followed by severe anemia and leukopenia. Affected children have congenital anomalies of skeleton, heart, kidney. Congenital hypoplastic or Diamond-Blackfan anemia refers to bone marrow failure limited to erythropoiesis only. 90% of cases are diagnosed by 6 months of age. At diagnosis, there is usually severe macrocytic anemia. The white cell count is generally normal and the platelet is often increased. The bone marrow contains few erythroid precursors. Acquired aplastic anemia. It manifests with signs of anemia, thrombocytopenia, hemorrhage, and decreased resistance to infections because of neutropenia. Cytopenia in blood count and hypocellular bone marrow obtained by needle biopsy confirms the diagnosis. Bone marrow transplantation is the treatment of choice for aplastic anemia. As many as 80% of fully compatible transplant result in a good outcome. Successful immunosuppressive therapy of aplastic anemia with anti-lymphocytic globulin, dexamethasone, and cyclosporine has led to complete or partial bone marrow recovery in 30 to 50% of patients. Symptomatic treatment of aplastic anemia includes red blood cells and platelets transfusions, granulocyte colony-stimulating factors, antibiotics, antifungal and antiviral drugs, intravenous immunoglobulin. Another group of anemias related to increased erythrocyte destruction are hemolytic anemias. They are classified into inherited with intrinsic red blood cells disorders, defects of cell membrane or defects of cell enzyme, glucose 6-phosphate dehydrogenase, pyruvate kinase, and acquired immune or non-immune. Most common type of congenital hemolytic anemia is hereditary spherocytosis, with abnormality of membrane protein spectrin that leads to a spherocytic red cell shape. Spherocytic cells are less deformable and unable to pass through the narrow pores in the splenic circulation. They become trapped in the spleen, resulting in hemolysis. Typical clinical symptoms of hereditary spherocytosis are anemia, jaundice, and splenomegaly. The main laboratory findings: decreased level of hemoglobin, increased reticulocyte and indirect bilirubin, spherocytes smaller than normal red blood cells in the peripheral blood smear. Hereditary spherocytosis can be cured by splenectomy because it eliminates the primary site of red cell destruction, but it should not be done before the age of 5 years to minimize the risk of post-splenectomy sepsis. Acquired hemolytic anemia has mainly immune mechanism. Autoimmune hemolytic anemia results from abnormal autoantibody production, complement or antibody-complement complex directed against the patient's own red cells. Coating of the red cells by immunoglobulin G or immunoglobulin M and complement leads to destruction of the red cell by macrophages in the spleen and liver, and usually confirmed by a positive direct CUM test. The predominant etiologic factor of autoimmune hemolytic anemia is infection, for example, upper respiratory tract viral infections, Epstein-Barr viruses, mycoplasma. An infectious agent can alter the red cell membrane, making it antigenic. In about 20% of immune hemolytic anemias cases, drugs are implicated. The drug, for example penicillin, binds to the red cell membrane and acts as a hapten. Antibodies to the drug can lyse the red cell. The onset of autoimmune hemolytic anemia is acute in 70–80% of patients, with a rapid fall in the hemoglobin level over hours. The child may appear acutely ill or even moribund, with tachycardia, tachypnea, signs of hypoxia and cardiovascular collapse. Jaundice, hepato and splenomegaly are common. Mortality in the acute stage is 9–19%. That's why to diagnose the disease in time is very important. Children younger than 2 years of age and older than 12 at onset are most likely to have a chronic cause with persistence of hemolysis or relapses. Laboratory findings typical for autoimmune hemolytic anemia are low hemoglobin level, reticulocytosis, indirect hyperbilirubinemia, and positive direct CUM test with the presence of antibodies on the surface of patient's red cell. The therapeutic approach for autoimmune hemolytic anemia generally begins with red blood cells transfusion and immunosuppressive glucocorticoid therapy, prednisone 2 to 6 mg per kilogram daily, should be given until the rate of hemolysis slows. Patients with life-threatening hemolysis need also high-dose intravenous immunoglobulin or plasma exchange. In patients with chronic disease who fail standard therapy, alternate immunosuppressive therapies should be considered. One of the newest therapeutic approach is MabThera or rituximab, genetically engineered chimeric mouse human monoclonal antibodies to target immune cells that have the CD20 marker on their surface, plasmacytes. If drug therapy is unsuccessful, splenectomy may be necessary. Before talking about the inherited disorders of hemoglobin synthesis, hemoglobinopathies, let's mention the structure of hemoglobin. Each hemoglobin molecule is made up of 4 hem groups surrounding a globin group. There are 4 iron atoms in each molecule of hemoglobin, which accordingly can bind 4 atoms of oxygen. Globin consists of 2 linked pairs of polypeptide chains, 2 alpha and 2 beta. Approximately 500 structural variants of hemoglobin have been identified. Hemoglobinopathies can result from mutations affecting the amino acid sequences of globin chains, sickle cell disease, and decreased synthesis of one or more of the globin chain, for example thalassemia, or combination of the two. Sickle cell disease. Sickle hemoglobin differs from normal adult hemoglobin by substitution of glutamic acid of its beta chain by valine. In the oxygenated state, sickle hemoglobin functions normally. Deoxygenation stimulates polymerization of sickle hemoglobin with formation of the structure crystal-like rods which deform the cell membrane and lead to the sickle shape of red blood cell. The rigid sickle cells may cause blockage of blood flow in the microcirculation. The consequence of cycling are both a shortened red blood cell survival and infarction of tissues. Infarction and aseptic necrosis of bones, viscera, lungs produces painful vaso-occlusive crisis. The spleen is similarly damaged and children have susceptibility to infections. Sickle cell anemia is diagnosed by the presence of sickle cells in the peripheral blood smear and sickle hemoglobin on hemoglobin electrophoresis. Treatment of sickle cell disease includes blood transfusion for reducing the level of sickle hemoglobin during sequestration and hemolytic crisis, painkiller in patients with vaso-occlusive crisis, antibiotics for all episodes of fever, and vaccination against pneumococcal and Haemophilus influenza infection. Thalassemia is another type of hemoglobinopathies. Thalassemia are heterogeneous group of inherited disorders of hemoglobin synthesis, all of which results from a reduced production of one or more of the globin chain in hemoglobin. Thalassemia can be classified into the alpha, beta, delta, beta thalassemia. Globin chains imbalance causes ineffective erythropoiesis and shortened red cell survival. Thalassemia manifests with severe progressive anemia, with pallor, jaundice, anorexia, fever, hemosiderosis. Compensatory hypertrophy of the erythroid marrow leads to frontal and parietal bossing of the skull, enlargement of the maxilla with protrusion of the upper frontal teeth, and bone pain. Extramedullary hematopoiesis in the liver and spleen results in massive hepatosplenomegaly. Growth is impaired, puberty is delayed. Diabetes mellitus resulting from pancreatic hemosiderosis, and chronic heart failure caused by myocardial hemosiderosis may occur. Typical for thalassemia laboratory findings are hypochromic microcytic anemia with target cells and nucleated red blood cells, elevated fetal hemoglobin, indirect serum bilirubin, and serum iron level. The main treatment approach in patients with thalassemia is red blood cells transfusion given on a regular basis. The major complications of chronic transfusion therapy include transmission of infectious immunodeficiency virus, hepatitis virus, and iron overload, hemosiderosis. Iron chelation with desferoxamine improves the prognosis. Bone marrow transplantation has been successfully performed in several patients with beta thalassemia major or chylomicronemia, but can't be routinely recommended because of its significant morbidity and mortality. Now let's start with oncohematological disorders. Leukemia is the most common form of children cancer. Acute lymphoblastic leukemia makes up about 76% of cases, acute myeloblastic leukemia about 20% of cases, and a chronic myelogenous leukemia makes up 1 to 3% of cases. Acute leukemia is the disease with malignant transformation and clonal expansion of hematopoietic cells that are blocked at a particular stage of differentiation and unable to progress to more mature forms. The disorder characterized by the replacement of normal bone marrow with abnormal primitive hematopoietic cells, so-called blast cells. In 1976, French, American, and British hematologists proposed FAB morphological classification of acute leukemia. There are three main morphological types of acute lymphoblastic leukemia. L1 typical with small cells, little cytoplasm. L2 undifferentiated, large cells, large cytoplasm. And L3 Burkitt type, large cells with basophilic cytoplasm and vacuoles in the cytoplasm. Another immunological classification based on recognition of blast cells differentiation with immunophenotyping using specific monoclonal antibodies, cluster of differentiation CD, to define cell surface antigens. Main subtypes of acute lymphoblastic leukemia are common acute lymphoblastic leukemia, pre-B acute lymphoblastic leukemia, B acute lymphoblastic leukemia, and T acute lymphoblastic leukemia. For acute myeloblastic leukemia, there are 7 FAB types according to the French, American, British classification. M0 with minimal differentiation, M1 without maturation, M2 with maturation, M3 promyelocytic, M4 myelomonocytic, M5 monoblastic, M6 erythroid, and M7 megakaryoblast leukemia. Most symptoms of leukemia are due to leukemic cell proliferation and infiltration of the bone marrow, resulting in bone marrow failure, anemia, neutropenia, thrombocytopenia, or specific tissue infiltration, lymph nodes, liver, spleen, brain, testes. Bone marrow failure manifests with signs of anemia, pallidness, fatigue, lack of appetite, signs of bleeding, purpura, mucosal bleeding, hemorrhages, and signs of susceptibility to infections. Clinical manifestations of tissue infiltrations with blast cells are bone pain, splenomegaly, lymphadenopathy, neuroleukemia, headache, vomiting, nerve palsy. Signs of systemic disease are also typical for leukemia: fever, weight loss, fatigue. Basic investigations required a diagnosis of leukemia are complete blood count and blood smear, bone marrow investigations, morphology, cytochemistry, immunophenotyping, cytogenetics, lumbar puncture with cerebral spinal fluid, cell count, radiological investigations, chest X-ray, ultrasound of abdomen, MRI of brain. Complete blood count usually shows anemia, thrombocytopenia, abnormal white blood cell count with leukemic hep. Bone marrow has to be infiltrated with 80–90% of blast cells. Bone marrow smears should be stained for glycogen, myeloperoxidase, acid phosphatase for distinction between lympho and myeloblasts. Immunophenotyping of blast cells, it means examination for specific CD markers, gives possibility to recognize B acute lymphoblastic leukemia, T acute lymphoblastic leukemia, or acute myeloblastic leukemia. Cytogenetic analysis can find translocations typical for leukemia with favorable or unfavorable prognosis. Acute leukemia should be treated with modern program chemotherapy. The total duration of the standard treatment course of acute lymphoblastic leukemia is 2 years. It divided into induction of remission 4 weeks with weekly vincristine and doxorubicin infusion, prednisone L-asparaginase. Most patients achieve remission, it means less than 5% of blast cells in the bone marrow, or minimal residual disease less than 0.0% on the 15th or 33rd day of treatment. The next step is CNS prophylaxis during 9 weeks with 4 intravenous and intrathecal methotrexate. Then consolidation of remission during 7 weeks, central nervous system irradiation during 2 weeks, and maintenance therapy during 1.5 years with oral methotrexate and 6-mercaptopurine. For patients with acute lymphoblastic leukemia who are treated with modern program chemotherapy, the rate of survival is 75%, and for patients with acute myeloblastic leukemia 30%. 5 years survival without relapse is usually considered a cure. The recurrence of leukemia after achieved remission is named relapse. There are 5 main forms of relapses. First, isolated bone marrow relapse. Only bone marrow contain more than 5% of blast cells. Second, isolated central nervous system relapse. Blast cells identified only in the cerebral spinal fluid. Third, isolated testicular relapse. Fourth, combined relapse with simultaneous involvement of more than 2 localizations. And fifth, isolated infiltrates of other sites, cardiac, pulmonary, which are very rare. Relapse can be on treatment or off treatment. On treatment relapse during treatment course is indicative of blast cells resistance to therapy. There is clearly a need for a bone marrow transplantation. Off treatment relapse after the treatment course and second remission can be obtained with second-line intensive systemic chemotherapy, and long-term survival is 39 to 60%. Chronic myeloid leukemia, like other hematopoietic malignancies, is a clonal disorder originating from the malignant transformation of a single multipotent stem cell. There are two types of chronic myeloid leukemia. Adult type, characterized by the presence of the Philadelphia chromosome in all hematopoietic stem cells, and juvenile chronic myeloid leukemia, when Philadelphia chromosome is absent. Philadelphia chromosome results from the translocation of the distal parts of the long arms of chromosomes 9 and 22. The new fusion gene is responsible for production of tyrosine kinase, which stimulates cell proliferation. It leads to granulocyte monocytic hyperplasia, increased production of erythroid and megakaryocyte progenitors. Chronic myeloid leukemia manifests insidiously with nonspecific symptoms such as fatigue, malaise, fever, abdominal discomfort due to an enlarging spleen, and bone pain due to marrow hyperplasia are also common. The diagnosis may not be suspected until splenomegaly or an increased white blood cell count are found on routine examination. The spleen may enlarge as far as into the pelvis. Chronic myeloid leukemia has three stages. First stage, chronic phase, fewer than 10% of blast cells in the blood and bone marrow. Second, accelerated phase, 10 to 19% of blast cells in the blood and bone marrow. And third, blastic phase or blastic crisis, 20% or more of the blast cells in the blood or bone marrow. The diagnosis of chronic myeloid leukemia is based first of all on the changes in peripheral blood. White blood cells may be greater than 100,000 with all forms of myeloid cells. Eosinophilia and basophilia may be striking. Initially, the platelet count is usually normal or increased. Anemia may or may not be present. The bone marrow is hypercellular with myeloid cells in all stages of differentiation, increased number of megakaryocytes. Genetic investigation of the bone marrow for Philadelphia chromosome is essential for diagnosis. There are 6 main treatment options for chronic myeloid leukemia. Target therapy with imatinib or Gleevec, chemotherapy, biologic therapy, high-dose chemotherapy with stem cell transplantation, donor lymphocyte infusion, and surgery, or mainly splenectomy. Target therapy is a type of treatment that uses drugs to identify and attack specific cancer cells without harming normal cells. Tyrosine kinase inhibitor is the target therapy drug used to treat chronic myeloid leukemia. Chemotherapy with a low dose of milsan, hydroxyurea, cytosine arabinoside stops the growth of cancer cells. Biologic therapy or immunotherapy is a treatment that uses the patient's immune system to fight cancer. Interferon is used to boost body's defense against chronic myeloid leukemia. High-dose chemotherapy with stem cell transplant can be done if compatible donor is available. Donor lymphocyte infusion may be used after transplant. Lymphocytes see the cancer cells and attack them. And splenectomy is recommended if the spleen is huge. The third most common tumor in childhood is lymphoma, which is characterized by enlargement of lymphoid organs, mainly lymph nodes, due to neoplastic process. There are two main types of lymphoma: Hodgkin disease and non-Hodgkin lymphoma. Hodgkin disease is a malignancy with mononuclear Hodgkin cells and polynucleated Ridge-Steinberg cells, representing the malignant cells and derived from immature lymphoid elements. The etiology of Hodgkin disease usually associates with Epstein-Barr virus. Genetic factors may be relevant to the disease also. The most common clinical presentation of Hodgkin disease is painless FEM lymphadenopathy in 1-2 lymph node areas. The growth of lymph nodes is slow. Fever, night sweats, and weight loss are noted in 30% of children. An Arbor stages classification for Hodgkin disease. Stage 1. Involvement of a single lymph node region or a single extralymphatic organ. Stage 2. Involvement of 2 or more lymph node regions or extralymphatic organ on the same side of the diaphragm. Stage 3. Involvement of lymph node regions on both sides of the diaphragm, which may be accompanied by localized involvement of extralymphatic organ. And stage 4. Diffuse or disseminated involvement of one or more extralymphatic organs. Each stage is divided into A or B categories, where A indicates no systemic symptoms and B indicates the presence of one or more of the following: unexplained weight loss greater than 10% of body weight in preceding 6 months, fever higher than 38 degrees Celsius, and night sweats. Widely used Rye histological classification divides Hodgkin disease into 4 types: lymphocyte predominance, nodular sclerosis, mixed cellularity, and lymphocyte depletion. For the diagnosis of Hodgkin disease, the biopsy from the most accessible primary tumor mass is essential. The plan of investigation should include complete blood count with signs of anemia, leukocytosis with eosinophilia, elevated erythrocyte sedimentation rate, then X-ray and CT scan of the chest, MRI and ultrasound of the abdomen, bone marrow biopsy to determine possible marrow involvement, and biochemical assessment of renal and liver functions. Combination of both chemotherapy and radiotherapy is highly effective in the treatment of Hodgkin disease. The number of courses of chemotherapy dependent from the stage of the disease, with subsequent involved fields irradiation in the doses 20 to 30 gray. With current treatment, more than 90% of patients with Hodgkin disease achieve remission. The likelihood of prolonged remission or cure is related to the stage at diagnosis. Most patients with disease in stage 1 or 2 will be cured, as with approximately 75% of those in stage 3 and at least 50% of those in stage 4. Another type of lymphoma, non-Hodgkin lymphoma, is a heterogeneous group of lymphoid tumors, high-grade malignancy of immature T or B lymphocytes with frequent extranodal disease, marrow and CNS involvement. As etiologic factor for non-Hodgkin lymphoma are mentioned Epstein-Barr virus, association with autoimmune disease, and immunodeficiency. All childhood non-Hodgkin lymphoma are classified into 3 types: Burkitt B-cell non-Hodgkin lymphoma, T lymphoblastic non-Hodgkin lymphoma, and anaplastic large cell K1 non-Hodgkin lymphoma. There are 4 stages of non-Hodgkin lymphoma in children. First stage, a single nodal or extranodal area. Second stage, 2 or more nodal areas on the same side of the diaphragm. Third stage, 2 or more nodal or extranodal areas on opposite sides of the diaphragm. And fourth stage, any of the above with initial involvement of central nervous system or bone marrow. The clinical manifestations of non-Hodgkin lymphoma depends on the site of primary tumor, which is painless with rapid growth within 1 to 2 weeks. Lymphoma of the chest manifests with cough and progressive dyspnea due to compression of the airway or to pleural effusions which contains lymphoma cells. Abdominal lymphoma presents as an abdominal mass with intestinal obstruction and associated ascites. Bone marrow and central nervous system may be involved. Systemic symptoms of fever and weight loss are not uncommon. For the diagnosis of non-Hodgkin lymphoma, excision biopsy of accessible tumor mass is essential with histological and histochemical investigations. Initial investigation should include full blood count, liver and renal function test, lactate dehydrogenase, myelogram, and cerebrospinal fluid examination. All patients should have chest X-ray or CT scan, abdominal ultrasound or MRI. Patients with non-Hodgkin lymphoma require program polychemotherapy due to systemic nature of the disease. For lymphoblastic lymphoma, treatment program similar to that of acute lymphoblastic leukemia. For patients with Burkitt lymphoma and anaplastic large cell lymphoma, regimens with high dose methotrexate and cyclophosphamide should be employed. With modern aggressive intensive chemotherapy regimens, the overall cure rates are 80 to 85% for B-cell non-Hodgkin lymphoma, 60 to 65% for T-cell non-Hodgkin lymphoma, and 60% for anaplastic large cell lymphoma. The last part of our lecture is devoted to the hemorrhagic disorders. Hemostasis, the arrest of bleeding from a damaged vessel, depends upon the interaction between the subendothelial collagen fibrils of blood vessels, the platelets and plasma coagulation proteins. Idiopathic immune thrombocytopenic purpura is a common disorder in children that usually follows acute viral infections and is due to platelet-associated immunoglobulin G, rarely immunoglobulin M, which increases splenic platelet destruction. Children with immune thrombocytopenic purpura usually present 1-4 weeks following a febrile illness with abrupt onset of petechia, purpura, and epistaxis. No adenopathy or hypersplenomegaly is present. Laboratory changes typical for immune thrombocytopenic purpura are in blood count low platelet level and normal red and white cell count. The bone marrow reveals increased marrow megakaryocytes and no blast cells. Immunosuppressive therapy with glucocorticoids and intravenous immunoglobulin is recommended for the treatment of immune thrombocytopenic purpura. Splenectomy and rarely cytotoxic drugs are used in the case of chronic or acute immune thrombocytopenic purpura with life-threatening bleedings. Disorder of clotting factor has the name coagulopathy. Hereditary deficiency of each of the plasma clotting factor have been described. Most clotting factors are carried on autosomal chromosome and heterogeneous are asymptomatic. Those on the X chromosome, factor 8 and 9, are the most prevalent clinically significant coagulopathies, presenting 90% of the cases of hemophilia. Hemophilia A factor 8 deficiency classified into severe form less than 1% of factor 8, moderate severity form 1 to 5% of factor 8, and mild form more than 5% of factor 8. The main clinical features of hemophilia are recurrent bleeding into joints, muscle, and soft tissues. For the diagnosis of hemophilia, important investigations are prolonged acute partial thromboplastin time and specific factor 8 assay. The main treatment approach for hemophilia A are replacement therapy with lyophilized factor 8, cryoprecipitate, frozen plasma, desmopressin, and epsilon aminocapronic acid. Thank you for your attention.